Is ready. Hello, welcome.
Hi, good morning. Can you hear me?
Yes, loud and clear.
Hi, good morning. How are you?
I told you we have a heat wave. So it's intensive
I'm
summer
so
again.
There you go.
Thank you,
It,
Dayre.
your name works for many reasons. You were coming and going a bit. Should I start or?
Yes, please start.
Okay, great. Thanks so much for the invite to talk. Um, uh, this is I wouldn't say this is a talk I've given many times, but Karen asked me to talk a little bit about COVID from the Canadian perspective, and particularly more specifically from the perspective of a pediatric hospital and some of the ways we contributed during the pandemic. So it's just going to go over a few of the things that at least I was involved with from an academic pediatric hospital in Canada's capital here in Ottawa. Some of the topics we'll briefly go over are COVID testing, decontamination of N95s, development of high-performing masks for our community, our contributions to caring for critically ill adults, and then the role pediatricians were playing at the vaccination clinics. So just quickly, I'm sure most of you know where Ottawa is, but there's Ottawa situated in North America on the left. Canada's got about 38 million people. Ontario, which is the province, Canada that Ottawa is situated in, has 15 million of those. And Ottawa formally has 1 million, but our catchment area is much, much bigger. It's a couple million. So we service that aspect of Ontario. We're very close to Toronto, at least by Canadian standards. It's about 400 kilometers down the road, and about 2 hours or 200 kilometers from Montreal. So one of the ways that my hospital contributed to the pandemic right off the bat was, I'm not sure how it works in other countries or in Austria, but in Canada and in our region, our microbiology lab was pre-pandemic responsible for all the respiratory viral testing in the region for children and adults. So at the beginning of the pandemic, when there was the need to start doing testing, that responsibility fell on our hospital. It eventually grew and expanded to our local adult hospital, the Ottawa Hospital, but initially that was us. Here's my kids on the right. In Canada, we play a lot of hockey, and this is them in their after-school program. And the rink that they would normally do their after-school program is there on the left. And you'll notice a theme through this talk where when they needed facilities to do things related to COVID, they tended to take over the hockey rinks in Ottawa. So this is the Brewer Arena, and this was where the very first testing facility was set up in Canada. So this is, I'm in the middle, you can't see me at the back, I'm all gowned up. I'm all gowned up and my hair is very different then. It's all grown out now, but that's me doing a testing shift at the Brewer facility. And then, so just for some perspective, we ended up doing our hospital about 10% of all the tests for the province related to COVID. So that's, I think they're getting up to about 1 million tests now. So that's one of the ways that a pediatric hospital was able to help both the public and our adult facilities. Moving on, the other way our hospital was able to contribute was really early in the pandemic, almost pre-pandemic, when we realized it was on its way to Canada, was that we had this realization that we were going to suffer through the same issues that other countries and cities and hospitals were dealing with, that our demand for N95 masks and surgical masks and PPE more broadly would exceed supply. So we had at least a tenfold increase in our demand. And for a relatively small hospital with about 160 beds, we were anticipating using 1.5 or more million surgical masks per year. So we were pretty concerned we were going to run out. So we established a task force, and I was part of that task force which had a couple plans to secure more PPE, which eventually the government took over, thankfully. That we were going to make some PPE if appropriate. Like many other places, we worked with our local maker community and colleges. Even some of the hockey teams got involved, and hockey companies, Bauer, etc. Turned their facilities into shield making companies, and then Plan C was to decontaminate and reuse N95s. And really early in late February, March in Canada, there were huge reservations about this. When this idea came up, there were complaints to our unions about this idea, and we really knew we were going to need a evidence-based approach to convince people and even our hospital that this was a reasonable thing to do. So we were unclear in late February, March, whether or not there would be any guidance come from the government or other organizations about face mask decontamination, when we really wanted to help keep our friends and colleagues safe. So we decided we would perform 4 systematic reviews looking at a couple different approaches to N95 decontamination to inform our hospital and our region. One of the issues we ran into was that systematic reviews usually take a really long time. Usually take months or years, but we had, actually I spoke about this years back, just at the very beginning of it, when Karen invited me over, where we had been exploring this idea of systematic review crowdsourcing to speed up systematic reviews. So we had done some validation work demonstrating that you could recruit a crowd online that was interested and divide up the tasks after a little bit of training and testing, and that they would just rapidly complete some of the rate limiting aspects of a systematic review. So we had published that work and then developed this platform that really just came online at the end of 2019, 2020. So we were able to use that platform, and in a matter of a month, we were able to do 4 systematic reviews. The first one, which was on ultraviolet germicidal irradiation, and we focused on it because we knew our hospital would have access to that through our basic science labs, as we were able to generate a rigorous, comprehensive, systematic review of the evidence within 7 days. So 7 days from completing the protocol, we were able to get the manuscript up on Open Science Framework and help our hospital in the region come up with a way to start decontaminating masks and put them in storage in case we needed. And then that led to a second one on microwave and heat, and a third one on chemical disinfectants, and then finally one on decontaminations of surgical masks. So, what we found, just very briefly, was that you could effectively decontaminate a mask using ultraviolet germicidal irradiation. The literature on this has changed quite a bit since this initial systematic review, but you could at least irradiate once, is what we found back in March of 2020. And vaporized hydrogen peroxide was also very, very effective and safe for some mask types. And then there was a little bit less evidence for microwave and heat, and there were very, very few studies on surgical mask decontamination. And there's some pictures there just showing our setup at CHEO. So there was a group at our research institute take the results and develop an in-house process for decontaminating the masks, and we used that process. We collected the masks and then decontaminated them and put them in storage in case we ran out. I'm happy to say that we came very close, but in the end we didn't run out and didn't need to use that store. But we had many other hospitals from a number of other countries reach out and use that information. So there was a lot of interest in this work at the time. The preprints that we put on Open Science Framework ended up having more than 6,000 downloads. The Journal of Hospital Infection responded and agreed to publish them all in the summer of 2020. There was a lot of government interest just because of the speed we could do this, because of the crowdsourcing, that there was a number of branches within the Government of Canada that were tasked with sorting this out and coming up with some answers, and they ended up turning to us and using our data and the manuscripts. And then it generated some media interest both locally and provincially and nationally and internationally. So that was fun to be a part of. Again, happy we didn't need to use it, and our procurement process worked, but came very close. The other PPE problem that our hospital helped deal with was, and again, I know that this was common elsewhere in the world, but very quickly in Canada we went to a universal community masking policy, and we're still, I'm not sure what things are like in Austria, but that's still the way it is today. We realized that this was going to be our reality for a while. One of the challenges we saw with that back in March, April of 2020 was that it was going to create unwanted consequences for the environment. I walk around my community and daily or every other day, and there's never a walk where you don't see at least one mask on the ground. There's the bin out in front of CHEO, the entrance. And one of the issues with the community mask was that we noticed early on was that a lot of them didn't have good fit. They had some filtration, but not great filtration. So we wondered if we could do a better job. So we set a goal to try to create a mask that had the 5F properties. So, improved filtration, good fit to limit leakage, fun or comfortable, friendly to the environment, and fiscally responsible. And I'm a doctor, not a textile expert or scientist, so we developed a team. We had a local company, Equitable, which employs largely marginalized population, largely immigrant women, and teaches them to sew and gives them work. And then Jesus, which is a textile scientist, and we put together a plan to source and test filters, some of which came from Austria. We developed a prototype, we did some wear testing, we did some fit testing, and then we made some implementation plans. And that took a while. In the context of a pandemic, it took some time, but all this work was done by December 2020, and we had been able to create a mask that had pretty good filtration for a consumer mask. It was greater than 80%, as high as 88% with the filter we found. And it was able to be laundered at home in the washing machine, for example, up to 50 times and still had filtration at greater than 70%. We did some quantitative fit testing, and with the quantitative fit testing, it performed similar, if not a little bit better than the standard surgical mask, about 15% leakage. We did a market survey at CHEO to make sure people would wear it and they liked it, and then we created it in 3 sizes, a kid size and a small and a medium. And shortly after we sort of finalized the development of this product, the American Standards for Testing Materials came out with guidelines for consumer masks, and we were happy to see that the mask we created, both new and after launderings, met their criteria. So, prior to wave 3, we were able to actually get this mask out into the community. We had a number made, and then we ran it as a fundraiser for CHEO. So we didn't know what to call it, so we called it the Ottawa mask. And we were able to do some promotion and get about 10,000 out into the community and give people a high-performing mask that they could feel comfortable and safe in. So another way CHEO can try to contribute and help keep the public safe. The fourth way was around Ontario's ICU capacity. So at the beginning of the pandemic in Ontario, we had about 400 ICU beds available for COVID patients, and the thoughts were that maybe with an all-in effort we could expand by an additional 900. So a lot of early efforts went into trying to, as people heard many times, flatten the curve and so that as it crept up, we'd have time to expand capacity. So with wave 1, which is shown there on the right, we had the peak was about 250 patients in ICUs related to COVID with wave 1. So wave 1 actually went really well in Canada, if I can say that, in that we didn't exceed our available ICU capacity, which is great. Wave 2, which came in early 2021, was a little bit worse than wave one for us. Got closer to 400, but again, our ICU capacity had been expanded and came close to filling up, but didn't exceed. And then sort of at the end of wave two was right about here that our politicians and our government thought it was all in hand and we had won and there was a vaccine available and they were starting to roll that out. And then, but unfortunately our vaccine, while there was approved vaccines, we didn't have a perfect or even, I would say, all that great. They'd probably not like me saying that, rollout strategy for our vaccines, and it took quite a while. So while we started vaccinating at least healthcare professionals in December, it took quite a while for Ontario to get its system set up. So we really weren't vaccinating well until April. So because of that, this sort of shows where we are. This is as of yesterday. So right now we're actually doing really well. We're about 75% of all eligible Ontario with at least one vaccine, and we've got about 25% that have had two. But because of this delayed response with our vaccine, we did have quite a significant third wave. And in early April, mid-April, we realized that we were going to exceed the adult ICU's capacity to handle COVID patients. So there was a number of pediatric hospitals in the province ramp up to start taking adults in mid to late April and early May. So CHEO was one of them. So we had a couple weeks warning where we could see this coming. So we were able to adjust get some extra nurses, train up some nurses, do some simulations, work with our adult hospital that's literally just across the field, and in the end we were able to take patients. They actually weren't patients from Ottawa. They ended up being flown in. A lot of them were flown in from Toronto because Toronto was the worst hit city in Ontario, if not Canada. So we had a couple weeks, 3-4 weeks, where we took adult patients from Toronto, and then actually we shut down, and then one of our other provinces in Canada, Manitoba, then had a really bad wave 3. So we ended up turning the lights on again, turning the ventilators back on, and taking some patients from Manitoba for a couple weeks. I'm happy to say that as of 2-3 weeks ago, things have settled enough that the adult ICUs no longer need us to do that, and we haven't had any adult patients for a couple of weeks. But that was a interesting experience for a pediatric hospital for sure. And then finishing up here, the fifth way, at least the fifth one I'll mention that pediatric hospital and pediatricians have been able to help is that we've been asked to pitch in and help with vaccinating and vaccine coverage. So, and that's, I guess, happening. Again, I'm not sure who's doing most of the vaccinating in other countries, but apparently in the U.S., pediatricians are helping, and here in Canada and in Ottawa, the pediatricians are helping do a lot of the vaccination clinics. Not saying our adult colleagues aren't, but we go over and we do the kids, and then we also do adults. So here's this is I'm on the left there, and then this is the head of our research institute, Jason Berman, and we were at one of the vaccine clinics. And again, it's Canada, so they take over hockey rinks. That's a different hockey rink. We're actually very close to our Prime Minister's house, but and his son has played at that rink. Oh, and then this is one of my pediatrician colleagues, Katie Baldwin, and she's vaccinating an individual who's 101 years old. Just got to say, as a pediatrician, feels weird to be looking after. I didn't do anyone that old, but a number of 95-year-olds. So that's always fun and interesting. So so those are some of the ways. I only had 20 minutes. asked for an hour, but Karen wouldn't give it to me. But some of the ways that a pediatric hospital has been able to contribute during the pandemic, there's sometimes a sense that it's been easy on the pediatricians or the pediatric hospitals, but we've tried to find other ways to help out. And then finally, I'll just mention that we are running, as everyone knows, Karen's leading a large vitamin D trial in adults that's going really well, and we have a similar one in kids that's been running in Canada. So we were funded just before the pandemic, which isn't a great time to be funded, and a lot of our research was shut down for quite a while, but we now have 6 sites up and recruiting in Canada, and we're at about 90 patients. So we're hoping for things to really pick up next year. Now that we've got 6 sites on board, we hope to have close to 10 within the next year, and our target is 700 patients. So things are going very well despite the pandemic, but we still got a long way to go. So again, thanks for the invite, and hopefully that was interesting, and curious to hear whether any of those were similar or different in Austria or other countries.